Invite Dr. Thomas Arun Vargese to give his talk. Dr. Thomas is a glaucoma and a neuro-ophthalmology consultant at Dr. Jacobs Eye Hospital, Cochin, Alfonso Eye Hospitals, Pala and Thodupuzha, St. Joseph's Eye Hospital at Kanyarapalli. He has 10 years of experience in the UK. He has a best paper at the Welsh Ophthalmic Forum in 2004, best paper in Synapse Neuro-Ophthalmology Conference in 2016. He's a speaker at national and international conferences and a quiz master at state conferences. I invite Dr. Thomas.
Thank you, Dr. Revati. I'd like to thank KSOS at the outset for this opportunity. My approach to disc edema, every case should be approached like a case of Sherlock Holmes, and I acknowledge my mentor in neuro-ophthalmology, Mr. Barr, with whom I worked in UK for 6 years. So these are 12 different cases of disc edema photos you can see, and the etiologies of all 12 were different. So how can you go about finding out what is the cause of disc edema in your patient? So approach should be with history, examination and investigations. In neuro-ophthalmology and in uveitis branches of ophthalmology, history has quite an important role. So you can ask for additional symptoms, and when you come to the examination, you need to differentiate true versus pseudoedema, unilateral versus bilateral, check the optic nerve function, general examination, blood pressure. Here I'm checking the superficial temporal artery, feeling for any fullness of the temporal fossa. All this can give you important clues as to the cause of disc edema. And additional ophthalmic features, again I'll explain to you about that, and when necessary, the appropriate investigations. You can use your fingers or you can use this hat pin for doing a quick confrontation visual field. And to check the pupil, you need to have one bright torch and one sort of diffuse illumination torch so that you can see the consensual reflex. True versus pseudo disc edema, you can see here on the left, the 5 C's that I use: the color, the cup, the contour, the circulation, and complete retina. On your left, you have the true disc edema, and the 2 important C's to differentiate versus pseudo is, one is the cup. The cup is actually lost late in true disc edema, unlike in pseudo. You can see the optic disc drusen and hypermetropia where the cup is absent. And M and F, I'm sure none of you will confuse with disc edema. And the second important C is circulation. Again, in pseudoedema, you can see all the blood vessels, the circulation very nicely over the disc, unlike in true edema where the blood vessels over the disc are blurred. Coming to the site of disc edema and the cause. So if it is unilateral, you're thinking a unilateral cause like a posterior scleritis, optic neuritis, AION, neuroretinitis. While if it is bilateral, you're thinking papilledema, ICSOL, hypertension, and a systemic cause. The additional features, this is what I really like you to focus on. The additional features are very important. So when the history additional points are pain on extraocular movement, you're thinking optic neuritis. Severe pain, the bottom one, you're thinking posterior scleritis. If there's a pallid disc edema, like I've shown here, it is AION. If the other cranial nerves involved, you're thinking of orbital apex lesion. If the retinal exudation, like the photograph I've shown here on the bottom right, you can see there's retinal exudation, you're thinking neuroretinitis. If there's choroiditis, or if there's, you're thinking tuberculosis, if there's proptosis, you're thinking an orbital mass. So these additional features, once you've seen the disc edema, look for the additional features, and that will give you important clues. In the case, again, bilateral with a macular fan, you're thinking raised ICT. This is the case you can see here. This is presented with disc edema, blurring in the right eye. You can see a disc edema, and you can see the extensile cotton wool spots and few splinter hemorrhages. So this straight away points to a systemic cause. He had similar finding in the other eye, but no disc edema. And this is a case of systemic hypertension. If there's anterior and posterior segment inflammation, you're thinking a uveitis, maybe a sarcoidosis, VKH. And if it's a bilateral optic neuropathy, you're thinking pituitary craniopharyngioma or a toxic cause. So a few examples here. So 47-year-old female, decreased vision in the left eye for 3 days. You can see the disc edema on the left eye, right eye is normal, and all the optic nerve functions were depressed. So thinking presumably a typical optic neuritis. And you can see typical optic neuritis behaves in a certain way, worsens for 2 weeks and starts improving by 4 weeks. And that is exactly what happened in this patient. So this diagnosis is only confirmed in retrospect. If it does not behave in that way, you need to think of other causes. Also, you need to think of other causes like NMO and MOG, but we won't go into that. Again, another patient I saw while working in the UK, decreased vision in the left eye for 3 weeks, and you can see there was a fullness of the temporal fossa, the disc edema on the left side, and a CT scan was done. As you know, bony lesions, CT scan gives a much better image, and the important clue was that the fullness of the temporal fossa gave the clue as to the cause. A very interesting patient I saw in Kanjinapalli is a patient with 29-year-old with headache and right eye pain. You can see the marked disc edema. When I examined, there was a doubtful choroidal elevation or a choroidal, you could say, serous detachment in the infranasal quadrant. Left eye was absolutely normal. And because of the marked edema and the exudation, I was thinking of an infective cause. So provisionally started on antibiotics and obviously did the TB investigations, which came as positive. And you can see the choroidal abscess which appeared, and this gave the clue. And ATT, with the ATT, the patient had a very good outcome. So important clue was the choroidal exudation and of course the new lesion. And this is the one I showed you. The macular fan points to a neuroretinitis. Again, optic disc edema, blurring in the left eye, and the other eye optic atrophy. So important clue from the other eye, this is a case of pseudo Foster Kennedy syndrome that we see more nowadays due to AAO1. So optic atrophy on one side, disc edema on the other side. Another lady again I saw one in the UK, 35-year-old on oral contraceptive pill with diarrhea. So this causes a hypercoagulable stage. She came with headache and double vision because of a 6th nerve palsy, and of course papilledema causing headache. And MRB, all cases of papilledema, MRB should be done, and this showed a superior sagittal sinus thrombosis, and with anticoagulation, she made a good recovery. So investigations in all cases of bilateral disc edema, definitely make sure you do MRI and MRB. So take home message, detailed history, focused examination, true versus pseudo, unilateral versus bilateral, look for additional features, just spend time on that. Points, sometimes go back to the history, systemic examination, blood pressure, investigations, blood and imaging, and that will give you the diagnosis. Thank you.
Thank you, Dr. Thomas Arun, for that wonderful presentation on papilledema.